given some changes that may be forthcoming. And so thank you everyone who was able to make time on very short notice. And with that, I'll turn it over to Ms. Degree.
Thank you, Chair Foster. I'm just going to go ahead and get my screen shared. Can you confirm that you can see that? And can you hear me okay? Yes.
Yes.
All right. And I'm going to turn it right over to Brendan. So please go ahead.
Well, thank you, Michelle, and thank you, Chair Foster, and thank you for inviting us here today. First, we'd like to start off by recognizing the extensive work of the AHEAD negotiating team over the last 6 months in supporting staff. From the Green Mountain Care Board, that includes member Robin Lunge, board member David Merman, and staff member Michelle Degree. And from our team over here at the Agency of Human Services, that includes Secretary Jenny Samuelson, Administrative Services Director Fran Hodgins, Health Services Researcher Jeff Batista, and Deputy Health Reform Director Sarah Rosenblum. So thank you to the team. Bit of background and context before we dive into the detail. Since the acceptance of Vermont into the AHEAD model in July 2024, the Agency of Human Services and the Green Mountain Care Board have jointly been negotiating with CMS on the terms for a potential agreement. While Vermont has not yet signed or been accepted, Vermont has been accepted into the AHEAD model, the state has not yet signed the estate agreement legally committing us to participate. In order to move forward with the currently negotiated state agreement for AHEAD, all 3 of Vermont state signatories must sign the agreement. Those include Governor Phil Scott, Agency of Human Services Secretary Jenny Samuelson, and the Green Mountain Care Board. An update as of yesterday, the governor has signed the agreement and has supported moving forward in cohort 2. And with that, I will hand back to Michelle to step through the state agreement, any changes and additions that have been made since our last presentation to the board on December 16th. Thank you.
Thank you, Brendan. So yeah, as Brendan said, I'm just going to go through a couple of changes that you'll note in the state agreement. I think most notably is that cohort selection, which Brendan just spoke to. So as you heard, the governor has signed a state agreement, and that state agreement assumes cohort 2 participation for the state. That means an implementation year of 2027, so January 1, 2027 start date instead of the cohort 1, which would have been 2026. So all agreement language has been updated to reflect that change. Additionally, the East Fund, we've had a couple of conversations about that. Just a note here that the negotiating team further clarified language in the agreement to ensure the state has access to the full East Fund amount. Medicare fee-for-service primary care investment targets. You'll recall perhaps that we had a preliminary and a final investment target determined by CMMI. Those were 4.47 and 5.17% respectively. We did need to sort of fill in what that would look like over time. And so we've done that. And I will go to the next slide to show you what that looks like. This is a screenshot directly from the agreement. So performance year 1, again, here we're talking about 2027 is that 4.47 rate. We opted to continue that through the second performance year for a couple of reasons. Most notably, just making sure that we're understanding sort of uptake in the program and able to get sort of that data collection process going and sort of seeing where we're landing. As you all know, data and data availability takes some time. Data lag is very real. So making sure that we can really see that kind of calculation as we're entering through the model years. Again, that final attainment goal does not change. It's 5.17. In addition, some appendix changes. I am getting a little feedback. I don't know if someone's not muted. In addition, some changes to the appendix in our current agreement, as well as in the proposed AHEAD model agreement. There are data custodians. Those are the folks who will have access to and work with CMMI on obtaining Medicare data. And so those contacts were named. It's Jeff Batista from the Agency of Human Services and Lindsay Kill from the Green Mountain Care Board. That information has just been populated into the agreement. So you'll see that change. I just really quickly wanted to go over sort of a reminder of these pre-implementation period and model milestones. So the pre-implementation period, assuming cohort 2 extends, right? So it was July 2024 when we were accepted into the model it would have been through December 2025 for cohort 1. Now it's through December 2026 for cohort 2. So just reminding you of sort of these timelines here. So all of these dates have been updated to reflect the changes, noting cohort 2 decision. You've seen this slide before as well. Key model milestones. What I did, I think, just to be a little helpful to the board in thinking about this in an implementation year, is took that first arrow and expanded it to add in what it will look like for hospital budgeting processes, assuming that the hospital regulatory framework in place is what remains. And so just adding in sort of other milestones within that to show kind of how this will integrate with our ongoing existing hospital budget processes. So you can see sort of the breakout there fits pretty nicely right in the middle with hospital budget guidance, and then budget submissions, hearings, and decisions. Again, this is just the sort of slide you've seen before, all of the dates updated to reflect cohort 2. We did want to go over some more recent public comment and some themes from that. The public comment that we had shared back on December 9th is in the appendix of these slides, so that's still there if you'd like to see it. Big sort of recurring themes in the most recent comments we've received: continued support of primary care systems and payments, so including things like MIPS exemption, Blueprint and SASH funding, and potential lost OneCare revenue. Monitoring of global budgets for unintended consequences, commercial insurance affordability, and then model evaluation and effectiveness, thinking about how we do this in real time and not sort of after the model is complete. And then some discussion around, or some comment around, OneCare waivers that are currently in place under their Medicare arrangement and how we might consider those in a future model. That's all we have in terms of slides to present. I imagine there's going to be a pretty robust discussion, so I'm just going to turn it back to you, Chair Foster.
Thank you. Thank you both. I'm going to open it up to any public comment, and then we'll see if there are motions. And I may need a short break before we turn to that. But I'm going to ask for any public comment via raise the hand at this time. And I'll note that we will take public comment after if there's a motion as well. But in the event there's not, I want to make sure we get public comment in. Ms. Molman, how are you?
Good, thanks. How are you, Chair?
Good, good. Nice to see you.
Good to see you. So my question is, let me get out of the dark first of all. There I am. My question to you and the team is there a plan for primary care support in 2026? We're looking at close to 20 or more than $20 million of funding that goes to primary care that will end in December 2025. Then we have a year gap before the model starts. So is there a plan to continue the Blueprint community health team funding, PCMH funding, SASH funding, and then anything to help close that gap for the OneCare Vermont population health payments? Those are dollars that fund real people that are providing direct services to Vermonters.
Sure. Good question. I'll turn it to Director Kraus if there's any plans at this time, or if they're still under development, if you can answer.
I just answered that they're under development, where we're considering all options at the that are available to us, and waiting for some clarity, I guess, on whether or not this moves forward, and that will help to frame our discussion.
Thank you.
Thank you for the very important question. Ms. Barnard, how are you?
Hi, good morning. Thank you. Jessa Barnard with the Vermont Medical Society, and also speaking on behalf of the American Academy of Pediatrics Vermont chapter and Vermont Academy of Family Physicians. And to run the risk of echoing what you just heard from Mary Kate and comments we also submitted publicly, I just want to really echo our concern with the gap year that would come about with cohort 2. So certainly really appreciate this is still on the table. There's a lot that the AHEAD model offers to primary care that would be a big loss if we don't even move forward with cohort 2. So I'm glad that is still, again, really something the board is taking seriously and thinking about. But even if that is the direction we go, we just want to echo Mary Kate's concerns about that year of all those potential lost funds and whether that's where those would be coming from and how we would keep primary care from really potentially disintegrating and then being asked to kind of have the bandwidth to jump into a new model after a gap. So thank you for just keeping that in mind as we move forward.
I'll just add, and thank you for the comment, but doing the model without sufficient primary care creates another layer of complexity, right? If you lose the primary care, you have a real problem with the model itself. Susan Ridson, how are you?
I'm good. How are you?
Good.
Just to beat a dead horse here, I just have to speak up. I'm Susan Ridson from Health First Independent Practice Association, and just want to give a particular shout out to the CPR practices who are used to getting these stable capitated funds, which will essentially go away in 2026. So have real concern for them, and pediatric practices, as we've mentioned in our written comments.
Thank you, and thank you for submitting the written comments. They're reviewed and considered, and we appreciate that. Ms. Wasserman?
Yes, I'd just like to reiterate that I have submitted lots of public comment. I think this is a flawed model. It's even more flawed if we're going to wait a year to make it happen, since it puts us in limbo. And it appears that if we said no to this model and put it aside, that it would actually make way to address the most pressing problems facing Vermont today. Thank you.
Thank you. Any other public comment? And after the public comment, I'll turn to the HCA. I'll turn to you in a second, Mike. I'll go to you last. Ms. Mian-Breeze, I hope I'm pronouncing your last name correctly. Sorry, you're muted though.
Thank you. You did get my last name right. Thank you. My name is Bridget Mian-Breeze. I'm a nurse practitioner with Gifford Medical Center. I also am on the board for VNPA. I'd like to echo my concerns about funding gaps that might occur that would affect primary care if we were to enter in cohort 1. I think it's imperative that we support primary care so that we're all ready to enter the AHEAD model. Additionally, I would like to urge the board to consider applying for some of the waivers that were put in place during the COVID pandemic that allowed nurse practitioners and physician assistants to be able to be more effective in delivering direct patient care in hospital settings, SNF settings, and in critical access hospitals specifically. I believe there was a letter that was submitted by VNPA, and I would urge you to take a look at that and consider some of our comments.
Great, thank you. Any other public comment? Thomasina Coates.
Yes, good morning, Ms. Thomasina Coates. I am a contractor with Medicaid on behalf of Blueprint, serving primary care practices. My question is, or the point I just want to put forward as public comment for consideration is, if we are in a gap year, what does MIPS reporting and federal reporting for primary care practices look like during that gap year? If these practices have to stand up that type of reporting to stay in good standing with Medicare, I'm concerned about whether or not that will be an additional impact that could affect the number of primary care practices we have at the end of 2026.
Thank you. I'll turn to the AHS team, and I'll add if there's a point, if we have a point of clarification about MIPS requirements in the model, that might be helpful too for people.
Hi, good morning. I'm Sarah Rosenblum, the Deputy Director of Healthcare Reform here at AHS. So with the gap year, we do anticipate that practices will have to meet MIPS requirements in 2026 as part of the AHEAD model and what we've negotiated with CMMI in the state agreement. CMMI will assess whether our Vermont's AHEAD model and the methodologies we have associated with that meet the requirements of an advanced alternative payment model, an AAPM. If CMMI determines that our model does meet AAPM standards, then providers would be exempt in Vermont from MIPS requirements. So that the exemption could come down in 2027, but I think we are still looking at a 2026 year of having MIPS in Vermont.
Thank you. Other public comment or questions? Okay, and I'll turn to the healthcare advocate.
Good morning, Mr. Chair and everyone. I am honestly collecting my thoughts, and you're getting an off-the-cuff comment here, which is kind of the way it always is for me. I'm a little bit in between the public comments that have come in so far. I want to echo the concerns about the funding for key parts of our healthcare infrastructure. Yes, SASH and Blueprint and primary care. And I also have had, and you've heard me say, I've had an ongoing concern or frustration that we've put all of our eggs in the AHEAD or the federal model baskets for a long time about how to fund these things. And so I think that has prevented us, stopped us from considering how to put our priorities in front and find ways to fund these key parts of our healthcare infrastructure. If they're a priority, we should make sure we fund them. So it's interesting to have this moment here where we're now considering cohort 2, which means that we're going to have to figure out how to put those priorities up front in for 26. And I have a little fear that if we continue to have our foot in the door for moving to the federal model for 27 and onward, and have this hopefulness that that is the answer to how we're going to fund these and other things, that it prevents us from doing the real work. And so maybe I'll just say, I don't know what motion is about to be on the table or whether we'll have another opportunity to speak, but any consideration of doing AHEAD, even in cohort 2, has to be coupled with a real assurance that we can and will leave it if it no longer works for us. That there's a lot that could be said right on that one. I know there's been a lot of discussion, and I'll just echo it, that we have the resources, that the board has the resources, and to hold up the regulatory side of this. And that is not at all assured, as I sit in the State House right now. And of course, I think, we are, to state the obvious, we are stepping into a place of having to negotiate with the Trump administration and in figuring out exactly what the global budget is going to mean. So that's continues to be an unknown for me about how that will actually look. And then I'll just add one more. I don't hear hospitals clamoring to get into this. And so it seems interesting for the governor and for the board to be sort of asking this question about whether we should, take this next step, commit ourselves to it without a real assurance that it does not work. We can't do it without hospitals thinking that it's a good deal for them, that it makes sense for them, and that they want to participate. So those are my comments for the moment, Mr. Chair. Thanks.
Thank you. I'm going to ask if there's any motion at this time from any board members. I'll give it 1 or 2 seconds here, and if not, I'm gonna request, or actually, I guess I'll just call for a 10-minute break. But are there any motions at this time? Okay. Let's take a 10-minute break, and I apologize to people, but I think it's necessary. And we'll come back at 9:05. And thank you for being here and for understanding the need for a quick break. So 10 minutes, 9:05. Thank you. Members Merman and Lungeback.
Yes, sorry about that.
Okay, great. Okay, we can resume our hearing, and I've have a few thoughts, and I'm prepared to make a motion. But first, I did want to thank Ms. Degree and Director Krause for the overview today. You, Pat Jones, Sarah Rosenblum, Jeff Batista, members Lunge and Merman, and many others have worked tirelessly to try and see if this model could work for Vermont and brought us to this point. I'd also like to thank Secretary Samuelson for her leadership and her personal involvement and immense work and commitment to exploring the model. The effort, though, goes far beyond the state. It includes VAHS, every hospital in the state, our other providers, Mark Hage and VHI, the Healthcare Advocate, Health First, private advocates, Vermonters, legislators, the governor, and the governor's office. I'm also sure I'm missing many, and more importantly, I also want to make sure I thank our partners at CMMI, who had phenomenal leadership from Director Fowler and Deputy Director Lukens, and our dedicated model leads Chris Kreider and Kate Sapra. They've been amazing to work with, and I appreciate their professionalism and their friendship. I have immense gratitude to CMMI for all they've done to get us to this point and give us this opportunity. Getting here has been a massive lift. The state owes all of those who put their blood, sweat, and tears into this a giant thank you. Taking the model further, sorry, somebody typing? Sorry, I just hear pecking. Taking the model further and implementing it beyond this will be an even greater commitment of resources in a far larger lift. Whether to vote to commit the state to another broad and complicated CMS model has been the hardest decision I have had to make since joining the board. We've moved this vote up. Originally, we were planning to vote at the end of June, so this is expedited, which has made it even more complex. Especially coming on the heels of the all-payer model, which did not live up to the promise of lowering healthcare costs and improving healthcare access in primary care. I'm not attributing that to the model, but it has not happened. AHEAD presents important opportunities. The terms that AHS in lead role and GMCB teams have negotiated are intriguing and potentially beneficial to the state. The model also ensures ongoing financial support for the blueprint, SASH, and funding for primary care. These dollars right now are incredibly important to the state and cannot be undervalued. If we do not do the model, and given the gap year, we will need to find a solution. On that, I do want to recognize that the state, AHS, the governor's office, and Green Mountain Care Board have been working hard to find opportunities to plug those holes. And I want to thank VAHS and the hospitals for their good faith efforts to work with us on that issue. We hope that there'll be a plan at some point in the near future. However, whether the model provides enhanced Medicare funding is unknown. Potentially it does. But at the same time, it's a cap on what Medicare pays us. And if utilization continues to increase, the cap could limit support from Medicare for Vermont. And that is the gamble. Is our utilization going to flatten out? In which case the model could be advantageous, very advantageous even. Or will utilization continue to grow, in which case we've shot ourselves in the foot and risked either rural hospital solvency or may see commercial rates continue to spike to plug financial holes in our system, which is simply not acceptable at this time. Thus, it would seriously jeopardize insurer solvency and Vermonters' ability to afford health care. Entering a model with these types of unknowns creates risk at a time when our healthcare system simply has minimal, if any, risk tolerance. It would be foolish to commit the state and risk the healthcare system stability for $20 or $30 million in blueprint, SASH, and primary care dollars in a $6 billion healthcare system. It does not minimize the importance of those dollars. It recognizes that it is a giant gamble, and that's concerning. I also think about our seniors and patient access. A Medicare cap, if it's too low, could further harm patient access and may provide an incentive for some hospitals to consider moving investments and resources into other areas of their business. They need to survive, they need to be financially stable. And if the cap is too low, it'll put them in a tough position. To monitor and regulate for these issues, particularly access, is vexing and takes tremendous resources. Our team is sorely under-resourced as it is. Designing and implementing a wholesale new payment delivery reform doesn't just happen. It takes scores of people to create and draft payment methodologies, write and implement policies, adjust payments, handle legal challenges, deal with service line change requests, exception requests, manage multiple different payer budgets, create an entirely new regulatory structure, and comply with the model's tracking and reporting requirements. If the model is not adequately regulated and sufficiently resourced, it will fail dramatically and harm patients and harm our health system. I cannot responsibly support this model absent the resources a large-scale reform like this calls for. If the all-payer model taught us anything, it's that assessing likely model outcomes is nearly impossible, and foreseeing unintended consequences is unachievable. Moreover, implementing and operationalizing a policy of this nature is exceedingly difficult and yet absolutely critical if it's to work. I worry that Vermont cannot successfully implement a model of this scale and scope. If we do it, there will be significant bugs, starts and stops, challenges, and misfires. And we need to accept that that's going to be part of this process if we're able to go forward in the model. I'm acutely aware that my fellow members have reservations, which I share. At the same time, the AHS team is bullish on the model, and they might be right, and I respect their views. It is very difficult to predict what will happen in the future, especially 9 years out and with an administration change coming at the federal level. On balance, I believe it's in the state's best interest to, at this time, not rush into the model, but also not to lose the opportunity if the model could potentially be favorable. Essentially, today, I'm weighing the ongoing cost and distraction of continuing to work toward the model versus the benefit of continuing to leave it open and maintain it as an option for the state, which I think is very important. The federal healthcare operating environment could soon change in unpredictable ways, and keeping the model on the table may be an important downside hedge and gives us time to continue to evaluate the model and receive feedback and gain greater assurances that the risks that are out there can be addressed and dealt with. Given that, I've prepared a motion that will allow the state to keep ahead as an option, but recognizes board members and many providers' concerns. This motion is a compromise. It protects the state from some of the bigger model downside risks and is made in hopes of garnering 3 votes. I'm going to make a motion, and if it carries, it does not prohibit the board from later revisiting and voting to revoke the automatic termination called for in my motion, nor does it preclude the board from otherwise voting to unilaterally terminate the model at a later date. Ms. Parker, would you be able to pull up the motion that I drafted?
Yep, I will do that right now.
I move that the board sign the state agreement with CMS to enter the AHEAD model, provided that the board automatically exercise the state agreement's termination clause under section 20.I if the chair, in consultation with another board member and staff, determines that any of the following has occurred, in which case the chair shall send notice of termination to CMS without further board deliberation or vote. Number 1, the board has not appropriated sufficient funding to hire the professionals necessary to perform model duties, or the positions are not approved. Specifically, 20 additional FTEs by July 1, 2026, with at least 5 to 10 of those additional FTEs by September 30th, 2025. Number 2, the board's global budget methodology submitted on or before January 1, 2026 is not approved by CMS as submitted or otherwise not approved in a form acceptable to the Green Mountain Care Board. Number 3, the board's regulatory duties, including with respect to payment reform, rate setting, and hospital budget regulation, are materially modified or altered in an unacceptable manner. Number 4, the board's regulatory duties are no longer performed independently. Number 5, a hospital directly or indirectly financially supporting non-Vermont-based hospitals enters the model. Number 6, a hospital that has directly or indirectly forgiven or is owed money from a non-Vermont hospital-based hospital enters the model. And I will ask if there's a second.
I'll second.
And I will open up the floor to board member discussion on the motion on the floor.
I can go ahead. Thank you for explaining your rationale and your thoughts, Chair Foster. So as folks know, I've been working on the AHEAD model with the rest of the negotiating team. And I certainly share some of the concerns expressed today and in other board meetings from my fellow board members. I do support signing the state agreement for cohort 2 to preserve the option to move forward and to preserve the negotiated financial deal that's included in the current state agreement. I hear and certainly understand the concerns that have been expressed today around the gap. I share those concerns, but I think on balance, given the need for additional time and resources, cohort 2 makes sense. The state agreement sets up a timeline for additional work, as staff have outlined today, including the finalization of a Medicare global budget methodology and other development of a commercial payment methodology, working towards total cost of care targets, which we currently have in our all-payer model, et cetera. I think having the additional time to develop those components and also the access and monitoring measures that have been discussed multiple times at board meetings makes sense. I personally think that the access and monitoring measures are necessary with or without the AHEAD model, and the AHEAD model provides us with federal funds to support their development, and I have concerns that there will not be the same resources available to develop those without moving forward with the investigation. The federal dollars that are available through the cooperative agreement can support this work, as well as the continued evolution of the board's hospital budget process. If we choose not to move forward in the next 2 years, those funds do not need to be repaid. So there is little financial risk in regard to that component. For me, the AHEAD model brings the possibility for additional Medicare funds to support Vermont hospitals and transformation. But in addition, it provides Medicare waivers and Medicare flexibility so that we have all payers at the table. While certainly hospitals receive most of their margin potentially on commercial payments, efforts in the past to proceed only on the commercial level have been unsuccessful because the public payers were not at the table. So having the public payers at the table to me is very important to proceed on an all-payer basis. The state agreement includes a 30-day withdrawal clause for the state, which does not require the state to have a reason. We can do it. We just have to say we'd like to withdraw. That's during the pre-implementation period. So again, I think the risk of moving forward is low, given that we have that withdrawal clause. To the healthcare advocates' point, though, we need to not be afraid to do that. And I think that articulating that this is a continued investigation and that we do have that possibility needs to be continued so that it's clear that the state is still weighing its options and that that's a real possibility in the future. Certainly, any Medicare model is not a silver bullet to solve all of Vermont's healthcare issues. No waiver is, and no healthcare reform is. Issues have to be looked at with specificity and a focus in terms of what are the necessary payer changes and provider changes to move forward with that work. So certainly I know many of my fellow members have expressed concerns. And while I don't necessarily share all of them, perhaps I'm a little less risk averse when it comes to this, in part because I think that the enforcement of these types of state agreements tends to be through a discussion and changes in the model to address unanticipated consequences. I am less concerned that there's a catastrophic enforcement at the federal level, but again, I think that's why the termination provisions are so important. So I think I'll wrap it up there and let others say their piece.
I'll jump in. So I too have been involved, although came on later than Robin and the negotiations and with the negotiation team with AHS in the model, and feel that that's given me a pretty interesting opportunity to really get into the details and understand it, I think, as best as I can at this point. I don't have as prepared comments maybe as some of the others, but I do want to bring up several issues. One is I really appreciate the public comment that we had earlier in this meeting, but I do think there's some interesting takeaways of that for me. One is that it was almost entirely primary care focused, and I do think that is a major concern of all of us here, and that is clearly been identified as the major benefit of this model. There were no hospital comments, and we haven't had any for a long time, and I do think that silence speaks volumes. I think that hospitals, my impression would be that I'm reading from that there's concern and hesitancy about engagement in this model, but understanding that there is benefit to primary care, and so this becomes a pretty loaded question. There was one passing mention of hospital global budgets by Mr. Fisher. And this is a hospital global budget model. This is a when it reaches the mid years of the model, this is a multi-billion-dollar a year hospital global budget methodology. And we're talking about $20 million a year of primary care funding. And trying to understand the relative importance and impact of these different needs has been really challenging, and I find that today's decision has been similar to Chair Foster. I think the hardest decision that I have had since I've joined the board. This is, I think, a very complex model, and it binds us to certain things. Although we do have out clauses, but it's hard to leave today. It's going to be hard to leave in a couple of years. The same reasons will still exist, that we're reliant on the model for funding primary care, and if the East Fund pans out the way it is, it'll be more than that. And that funding's good. That funding's important. We want that funding, and we want to do those programs, and those are incredibly important for our state. But it's difficult to assess the cost associated with that funding. So some of the things I've been thinking about this is, I think, and I wasn't on the board at the time, but I think when we started talking about global budgets, I think the general thinking among people looking at health policy and healthcare reform in the state was that we have an unnecessary utilization and overutilization problem, and that global budgets are a way to manage that problem pretty effectively. I think that we get into the right care, the right place at the right time, and we think about that. And I think there's opportunity within global budgets to manage that. And I think that's part of why Medicare really likes it. They have effectively, with the exception of critical access hospitals, have standardized pricing. And so with standardized pricing, when you try to save, if they're trying to reduce their expenses, it's through reducing utilization. And so global budgets, I think, in my view, are really a tool to try to mitigate unnecessary utilization, overutilization, and reduce utilization in a way that I think ideally allows for some flexibility. And there's some, I think, advantages to that. One area I think of often is palliative care, which doesn't particularly do well with revenue generation, but is incredibly important to patients and families in our community, and is actually quite cost effective as well. I think that the problem that we have in Vermont actually turns out is not so much overutilization, but it's pricing. And this model could get at that. There is potential to get at that, but it's definitely it's going to take some work to get at that within a global budget methodology, especially based on, if we adopt a similar Medicare methodology for commercial, which would be based on historical spending. I worry a lot that this model will incentivize reduction of access to care within hospitals and stenting of care within hospitals. And I think that there's pretty good theoretical evidence of that and real world evidence that we see within the Maryland model of reducing hospital bed capacities, increasing ED wait times, boarding times, and hospitals reducing services. And those services then sometimes pop up outside of hospitals, which is a potential benefit, lower cost, more access, more choice. But I do worry that in many of our communities, there isn't the population there to support those independent practices at the volumes that would be needed for them to be viable. There are things that I actually do like about AHEAD quite a bit, and I think that we've talked a lot about those this morning, which is primary care funding, Blueprint, SASH funding, waivers, and the East Fund, which we haven't actually talked about at all today, is the opportunity to build a fund, other than actually Ms. Degree brought up the language in her slides, but the opportunity to build a fund that we can use to support services that do not typically generate revenue through a fee-for-service system or in other ways within this model. And the things that I think of in that are home health services, substance use treatment, some mental health services, long-term care, and those sorts of things. So that is highly appealing to me. I do think it helps incentivize more care to be delivered out of the hospital, although I'm concerned it does it through rationing and stenting. And it will increase the regulatory levers that we have it will need to manage hospital budgets. But I do see, and I've mentioned this before, just a lot of risks. I do think that, similar to Chair Foster, capping Medicare funding in the state, if we don't get that exactly right and we can't keep our Medicare spending down, does provide a lot of risk. Now, we could always leave, that's true, but in the process, we will cut into our ability to fund the East Fund, to fund primary care, to fund the Blueprint. As I mentioned, big concerns about rationing and stenting within hospital care. And I think that in all of this, we've had so few discussions about the complexity of building a commercial global budget methodology. Maryland does this. It's a huge lift. There are other ways of doing it. They all have operational and legal challenges that are pretty substantial, and this needs to be worked out in a couple of years. I think we've underemphasized the complexity of this and how heavy of a lift this is going to be, and the risk associated with getting this just right or not getting it right. And as Chair Foster mentioned, there's going to be fits and starts. I don't remember the words he exactly used, but this is not going to be a super smooth process. This is going to be an iterative process. I think talking with Maryland, 40, 50, 60 adjustments per year in the first few years to how their methodology was implemented. So this is not like a, you just grab it off the shelf and pop it and here we go. This is a very, very complicated project that's going to be, we're going to have a lot of unpredicted challenges with this. So on balance, I very much struggle with this. I think that this is not the appropriate way to support our primary care infrastructure in Vermont. I feel like primary care funding is effectively being held hostage by Medicare, statewide agreements. I think this is a multi-billion-dollar model for $20 million of primary care funding. Maybe we'll be able to work out more than that with the East Fund, even substantially more than that. And I do think but on balance, actually, I do agree with Chair Foster and Member Lunge that at least for the foreseeable future, because of the tenuous state largely of our primary care infrastructure in Vermont, that we need to keep this option on the table for the foreseeable future, but with eyes wide open and ready to move away from it while simultaneously working out other funding mechanisms that are more sustainable than a model like this. Thanks.
I can hop in here, and I can tell that all of us share some of the same concerns and some of the gravity of this decision. And I want to actually also acknowledge and appreciate all the hard work that AHS and the Green Mountain Care Board team have done to consider the merits of this model and to negotiate the best possible deal. And I want to also express, appreciation for all of the public comments that we've received. There is certainly some upside potential to joining the model, particularly for primary care providers, and that can't be underestimated. That being said, I will be abstaining today from the vote, and I really deeply respect those who feel confident in supporting the model. But at this point, I cannot vote in the affirmative, even with the conditions here that I think do mitigate some of my concerns. And since I don't think I've ever abstained from a board vote, I thought it would be helpful to share some of my comments of how I landed here. Like others who have talked before me, I certainly place great value on the critical primary care dollars and the Blueprint and SASH dollars that are tied to the model. But I also agree with the healthcare advocate and Member Merman and others in that we need to find ways to fund these incredibly important programs without linking to what I believe is a risky federal model to be executed under a new administration. At this time, I think my abstention comes from I've not seen enough evidence that net of implementation costs, we would be financially better off under a head. A full financial analysis of the expected funds flow from Medicare under various assumptions regarding MA penetration, which we know is going to grow, utilization growth, which has been particularly high in the last couple of years, assumptions around provider participation, all of that is actually still forthcoming. And without seeing those projections and the confidence intervals around them, I can't vote yes. I've also not seen a full risk analysis of the model. Without a risk assessment, we cannot really adequately monitor and guard against unintended consequences, such as low margin but high value service line cuts, like cutting primary care, cutting mental health, care rationing, as Member Merman mentioned, and stenting, movement of Vermont global budget dollars out of the state by hospital networks, unintended consequences of increased pressure on commercial ratepayers if the Medicare funds are not enough. These are all really deep concerns of mine, and I haven't seen a risk assessment of that or strategies to mitigate against those. I haven't seen adequate evidence that our fragile healthcare system is prepared for this transition and the financial risks it entails. I would need to see that. I agree with the healthcare advocate and Member Merman. It's notable that we have not seen an outpouring of enthusiasm or support from the hospital community. I will note that's a significant departure from where we stood before we agreed to the all-payer model. Back then, we had, I think, a deeper analysis of the model and more enthusiastic provider support before we signed. The lack of strong hospital support gives me pause. Either hospitals and other providers don't fully understand the model and its implications, or they don't believe it's going to provide them with additional federal resources. So it gives me pause. As the chair noted, and others have noted, Member Merman and Member Lunge have noted, this is going to be a big lift. Implementation of this model is going to command a lot of state resources, time, and attention. Those resources have not yet been committed by the legislature or the governor. It's not clear they will be. I appreciate the conditions imposed on this motion, but I still have a lot of concerns that we will not have the resources to successfully implement this model. And I guess I would just say, I've not seen enough evidence to show that this is the best allocation of those scarce state resources, even if they are done that way, allocated that way. It's possible that right-sizing the hospital system through Act 167 care transformation, perhaps implementing provider rate setting, reference-based pricing, finding some dollars through the care transformation and a different pricing scheme, and shifting those liberated dollars to primary care, to mental health, to long-term care would have a greater impact on healthcare costs and population health. So since I've not yet been convinced that state investment in AHEAD has a higher ROI for Vermonters than some alternative payment and delivery reform efforts, and I think there's some significant risk, downside risk to the model, at this point, I'm going to abstain from the vote today.
Well, like other board members, I want to take an opportunity to thank everyone who's been working on this for more than a year now. There have been late nights, great uncertainty, much back and forth. It's been difficult for everyone for quite a long time. When we began, and I'm sorry, I don't have prepared remarks, so I may ramble a bit. I'll keep it as short as I can. When we began to build our capacity as a board to assess the performance of the all-payer model, the first agreement, and we found that it wasn't delivering the results for the state that we'd hoped. We felt our hands were tied. There was very little that we could do to leave the agreement or alter it. That model, in my personal assessment as one board member, failed. There's much about this model that is built off of that. I've worried from the beginning that the AHEAD model was not designed to meet the needs of Vermont now. It was designed by Medicare to reduce or cap Medicare expenses. That's not what Vermont needs with an aging population at this time. We've negotiated and achieved some remarkable successes with our negotiation. But still, I do not believe this model addresses our largest concerns currently. And I don't believe that our assessment to date has included key details like the cost of implementing and monitoring the model. The first model cost the state of Vermont, to the best of our estimate, $100 million. Our healthcare system received tens of millions of dollars to transform. There's been little notable transformation. Commercial prices have risen among the fastest in the country. Access for Vermonters has declined, and quality has, at best, stagnated. I've seen nothing in the discussions of this agreement that would address those issues straightforwardly and adequately. Other members have discussed the lack of hospital support in public comments and in these meetings. Member Holmes just mentioned that there was more robust support for the first model. I was not a member of the board at the time, but my recollection of the first few years of the model was that it was very difficult to achieve enough participation for it to perform. This model, we have discussed, for it to succeed, may require mandatory participation. Yet that is now completely off the table in any of the agreement. I believe, while everybody has been working with the best interests in mind, that the discussions of this model have been a tremendous distraction for us and for other leaders in the state. We've not addressed urgent primary care needs and mental health needs now. We've not addressed rising prices to the degree that we could have with more focused and determined effort. We have not explored alternative waivers through Medicare that may help better address our pricing, access, quality, mental health, primary care needs. I was not aware this morning that the governor signed this agreement last evening. That complicates my thinking this morning. I was not aware of the wording of this motion this morning. That complicates my thinking. And while I would like to agree, and I do not like being the person who says no and stops what could turn out to be a beneficial model, I have not seen in the last year enough progress that would suggest 12 more months of continued negotiation would be sufficient to get us there. For the reasons that I've outlined here, and I think more articulately in prior meetings, I'll be a no on this vote.
Thank you. And I appreciate each board member's views. Member Lunch?
Yeah, I had an assumption that I wanted to test on a couple of the conditions and just a couple other reactions to folks' thoughts, if that would be okay.
Yes.
Great. So I would just say, Dave, I think that the work on the hospital global budget came out of the Rural Health Services Task Force and the sustainability effort. So I think the hope is that it could potentially provide a predictable funding source, and that depending on, of course, the design, that there could be ways to provide some base sustainability that would actually support the transformation recommendations in Act 167 in that work. So that's how I look at it. That, that's just one person, obviously, but from at least my work on this, that's, to me, where it came from. Also, quite frankly, that I don't think that a fee-for-service payment infrastructure underlying our budget process provides the right incentives. And since we already have an enforceable cap, I think the payment structure could all work better, in my view. On I think I certainly don't want to make light of the ability to leave, because that certainly has been hard in the past. Although I think having this sort of frank conversation up front makes it easier. But also, I do think we have to keep in mind, this isn't a light switch. To everybody's point, it needs to be iterative. There's the option for it to be iterative, and it's not a block grant. So, the fee-for-service funding infrastructure for certain providers continues, and it's really ensuring that the global budget, if that's not working, we fix it, or we, withdraw, as we've discussed. On the Medicare waiver point, there are no other options to receive these Medicare waivers other than the existing ACO programs that are open for provider participation. So, I think that has been explored in terms of, is there another option for the state? But Medicare waivers are not like Medicaid waivers. States can't just request them. CMMI does specific models, and they've been very clear that they're moving away from state-only models. So any opportunity for that has been closed. There is, I think, opportunity for providers to join existing ACO programs, most of which at this point, I believe, are probably out-of-state ACOs, and other Medicare models that are off the shelf. So my assumptions that I wanted to test, Owen, were for the conditions 5 and 6 around the direct or indirect financial support of non-Vermont based hospitals. I think what we're shooting for here is to ensure that under a global budget model, hospitals wouldn't move care out of state, because that certainly may not be in the best interest of Vermonters. And that we ensure that that model is supporting Vermonters and Vermont hospitals in the right way. Is that a fair assumption of my read?
Both. And I just want to flag, there are folks coming in at 10 a.m. this morning for a meeting. I don't want to hold them up too late. But yes, well, the intention is to find a path to get 3 votes is one piece of it, but then the other is that we want to ensure our healthcare dollars are staying in Vermont now and in the future.
Thanks. That was it. Just wanted to make sure I was understanding it correctly.
Yes. I'm going to ask for a public comment at this time. Actually, I'm sorry. I'll go to the healthcare advocate first if they have anything additional.
No additional comment at this time, Mr. Chair.
And any public comment in addition to what we had earlier, which we greatly appreciated. Ms. Ridson.
Hi. Thanks for all the discussion. I really appreciate the comments around the heavy lift of this model, the unclear outcomes, the risks and the uncertainty, whether or not the risks outweigh the benefits. I also appreciate Dr. Merman's comments about the desire to not hold primary care hostage with this model. I do have serious concerns about cohort 2 really negatively affecting primary care, though. It's sort of the worst case scenario because I have not seen or heard a clearly articulated plan B for those practices to, make them whole. We have the MIPS issue. So I just want to express my concern around that. Thank you.
Thank you. Seeing no other hands at this time, I think we'll need a roll call vote on this. And I'm just going to say something that I'm hearing and feeling, which is there's an incredible array and spectrum of views on this, right? From within the board, within AHS, within staff, within the hospital, within the provider community. And I think that just speaks to whatever is weighing on everybody today, which is the complexity and uncertainty and wariness and concern for our health system. So I just want to recognize that. And if Mr. Barber is here, which I assume he is.
Before I take the roll call, though, there is a blank space in the motion that I don't know if needs to be clarified or removed. I think that's probably up to the maker of the motion and the seconder. So
Yes, thank you. So given the feedback, Member Holmes has indicated she's not prepared to vote at this time, and Member Walsh has indicated he's not prepared to support the motion. That leaves Member Lunge, myself, and Member Merman. I think to many of us, with sadness, Member Lunge will not be here in after April or around April. So I would say that given Member Merman is a potential vote and that he has been involved in the negotiations, it is logical that it would be Member Merman.
And I would certainly support that.
So I'll make a friendly amendment to my motion to add in Member Merman there.
okay, are you ready for the question, the roll call?
Yes, please.
Okay, I'll just go in alphabetical order. Board Member Holmes, if you could just state your
Abstain.
abstention on the record. Thank you. Board Member Lunge,
Yes.
Board Member Merman,
Yes.
Board Member Walsh,
No.
and Chair Foster.
Yes. Thank you, Mike. Okay, the motion carries. I appreciate the difficulty of this and the significant work ahead. Thank you, everyone, for attending and commenting and participating in the process to get us here. I will ask if there's any old or new business for the board at this time. Seeing none, I will move to adjourn.
Second.
All those in favor, please say aye.
Aye.
Thank you, everyone. Have a nice day and a good weekend, and we are adjourned.